The following presentation identifies the important areas involved in examination of the newborn child. Newborn babies are routinely examined in the first 24 hours of life and again at 8 weeks to screen for important congenital abnormalities. The examination is also an opportunity to identify normal variations and to provide health information relevant for all parents. You can see here the consultant undressed the baby for the examination. This enables the examiner to obtain vital information about the baby's tone, state of alertness and general neurology.
I'm going to lift up her head.
Starting at the head, we feel the sutures and the fontanelles. The ears are assessed for position and shape, plus identification of any skin tags, pits or any other abnormalities. The mouth is opened and checked for swellings. A finger is gently inserted to feel the palate. This also gives the opportunity to assess the baby's suck reflex. The baby's eyes are examined for presence of a bilateral red reflex. This is done by using an ophthalmoscope set on +6 around 12 inches from the baby's face. This baby is very cooperative in opening her eyes, but if found difficult, placing the baby over mum's shoulder will encourage the baby to fully open her eyes. We measure the head using a disposable tape measure and are aiming to read the largest circumference of the head.
Okay. And then what I'm going to do is I'm going to reposition the tape.
You should take 3 separate readings and use the largest of these.
A consistent reading.
This should be accurate within 0.1 to 0.2 of a centimetre.
6 centimetres.
Lastly, within the head examination, the skin folds of the neck are checked for evidence of infection or other abnormality. Moving down the body, the clavicles are palpated to identify evidence of birth trauma.
You won't be able to see anything.
Note the baby's symmetrical movement, seen here with a normal cry. The brachial pulses are assessed.
Feel her pulses. And then the next thing I'm going to do is I'm going to look at her hands and open her hands.
Hands are open to examine palmar skin creases and to accurately count the fingers.
And I'm going to count the fingers. So
Moving on to the chest is examined for asymmetry and for abnormal pulsation. The apex of the heart is located, feeling for heaves and thrills. As you can see here, the heart is then auscultated in the standard 4 areas as you would in a child or an adult. It can be difficult to hear murmurs in little babies because their heart rate is normally between 100 and 160 beats per minute. Remember, transient murmurs in the first day of life are often due to closing ductus arteriosus. Moving on to the abdomen, the cord is inspected to make sure it is clean and dry, with no evidence of redness on the skin surrounding the cord. The abdomen is assessed for symmetry and to ensure there is no distension or obvious masses. Palpation then starts in both iliac fossae, working up towards hypochondrial regions. This ensures that a large liver or spleen or a large mass is not missed. Next, we feel independently for the spleen and again for the liver, which is normal to feel as a soft edge up to 1 centimetre below the costal margin. The kidneys can be ballotted and are often easy to feel in the first day of life. The femoral pulses are palpated, and it is important to note if there is a difference in quality compared to the brachial pulses. In coarctation, the pulses are absent or difficult to feel. Radiofemoral delay is not present in infancy as a sign of coarctation. The genitalia are then checked. The anus is checked for patency, and it should be established whether the baby has passed urine and meconium. In boys, it is important to check that both testes are descended.
Oh, she's not going to let me do it just now. She's having a very go.
The hips are checked for stability using the Barlow and Ortolani manoeuvres. This involves the potential dislocation and relocation of an unstable hip. As can be seen in this baby, it is important to have the baby relaxed and on a firm surface before this manoeuvre can be adequately performed. When the pelvis is stabilised, the hip and knee are flexed to 90 degrees. Pressure towards the bed is then applied. Any posterior movement suggests that it has been possible to push a dislocatable hip out of the acetabulum. Following this, the hip is then abducted. A palpable clunk will be felt if a dislocatable or dislocated hip is relocated. Here, the examiner is looking for equal upper and lower segments of the legs and no difference in skin creases between sides, which may be an indication of hip asymmetry.
Her feet.
Moving on to the lower part of the body and the baby's feet. We can see the baby showing a normal grasp reflex and a fully mobile foot, which can be dorsiflect to the shin and inverted and everted to 90 degrees, excluding any degree of fixed talipes. Once again, skin creases are assessed and the toes counted.
1, 2, 3, 4, 5. Okay.
The baby is placed in ventral suspension to check for midline defects down the back and to palpate the spine. Any pigmentation or unusual skin lesions over the spine are potentially significant and may suggest an underlying spinal defect. The buttocks are parted to check for natal dimples. Note this child has a stalk mark or nevus flammeus on the nape of the neck, which is a very common normal finding. Identifying normal primitive reflex is important in assessing neurological status in infants. Identified here is the stepping reflex. When the baby is tilted forward, they should initiate walking type movements. The most identified reflex is the morrow reflex. With the baby supported and relaxed, the head should be held in the midline. By dropping the head back, we see abduction and then adduction of the hands symmetrically. From this examination, information has been gathered that identifies that this baby is showing normal newborn neurological behaviour. She's turning to light and sucking forcefully on a dummy. She is showing normal symmetrical movement and normal tone. The examiner is able to reassure her parents that she is a normal baby.